Let's get started. So thank you everyone for joining today. We really appreciate your time, knowing that you're all very busy folks with many things on offer. We're here today to present some work that we've done on expert views about state-level policies for the treatment of opioid use disorder. My name is Sean Grant. I am a project co-investigator for one of the projects on the RAND-USC Schaeffer Opioid Policy Tools and Information Center of Research Excellence, also known as OPTIC. I'm an adjunct scientist at the RAND Corporation and full-time am a research associate professor at the University of Oregon. And I led some of the work that we will be discussing today. So why are we here today? Here is the conversation, the presentation in a nutshell. Hopefully this is why you're here. Our motivation are that state policies are an important lever to increase access to evidence-based treatment for opioid use disorder. So what we did based on this motivation was an online expert panel where we explored experts' views on treatment policies to examine whether or not there was consensus on policies that are high value, which we deem as policies that are effective, are implementable, and are equitable in their impacts, versus ones that are low value, which would be ineffective if not harmful, difficult to implement, and inequitable in any positive or having increased. Our main takeaway from the work that we've done and that we'll be going over today is that in general, experts viewed supportive policies as those that improve engagement and retention in OUD treatment. So those would be the ones that they would recommend considering, and considering the de-implementation or not adopting policies that take punitive approaches to try and improve engagement and retention in OUD treatment. I'll unpack today what we mean by that. I wanted to end with a main resource that has come out of this work. If you have a phone with a QR code, there's a little square there you'll see in the bottom right corner. We've created what we call our OPTIC policy profiles, and those summarize how our panel of experts rated each of the 14 policies that we had them assess in this panel, and also summarizes their views on different criteria about those policies. And we'll introduce those at the end of the chat today. So the roadmap for the next hour is that I will review the rationale and the methods that we used for our expert panels. I will then go over the expert consensus and recommendations about the state level policies, unpacking their ratings, themes that we saw at the level of the entire panel, and then themes that we saw according to different criteria or different types of policies. And again, at the end, I'll introduce you all to our OPTIC policy profiles that you can use and share with others who are making decisions or having discussions about state level policies to increase access to OUD treatment. So let's start with the rationale, the importance of state level policies and understanding their effects and implementability. So as I'm sure many of you all know, despite broad efforts to address the opioid crisis and some recent gains in addressing that crisis, opioid-related overdose deaths still continue to reach record highs and remain a public health priority. And of the many things that we're doing to try and address this issue, a cornerstone of the national strategy to mitigate this crisis is improving access to effective treatments for opioid use disorder, particularly medications for OUD, and ensuring the provision of high-quality treatment to achieve equitable outcomes for vulnerable populations. And as I'm sure many of you know, substantial barriers to MOUD and other evidence-based treatments continue to exist, and structural, systemic, and institutional barriers continue to yield disparities by race and ethnicity, income, geography, and other social gradients in the United States. We think that state legislation and regulations, or state-level policies, offer one important mechanism to improve access to and the quality of OUD treatment. And during the past decade, federal, state, local, and organizational efforts have expanded the number of clinicians offering MOUD, strengthened collaborative care models, allowed for more flexible treatment processes, have done numerous things to try and use state policy as that mechanism. But as you probably also know, evaluating state-level policies is a very challenging empirical endeavor. We know that MOUD at the individual level can improve treatment retention, reduce opioid misuse, and is associated with a decrease in important outcomes like overdose rates, recidivism, and opioid-related hospitalization. But it is more challenging to assess the effects and implementation of state-level policies that are intended to improve treatment engagement and retention at the population level. Some reasons: state-level policies are complex, they're composed of multiple overlapping components, and they're inherently difficult to measure or classify. In addition, real-world data that links treatment receipt to treatment outcomes is commonly limited to a single jurisdiction or insured population, which limits generalizability, or maybe it's characterized by unknown data quality or missing niche issues. And state level policies are not always effectively implemented on the ground, and these difficult to measure aspects of implementation are also key moderators for associations of state policies with patient and population level outcomes that we care about. So partially because of these challenges, existing evidence, empirical evidence of how state level treatment policies are associated with treatment and subsequent health outcomes is generally mixed or incomplete in a lot of cases. But given the importance of high quality evidence-based treatment for addressing the opioid crisis, there's an urgent need to better understand which state level OUD treatment policies are effective in addressing opioid related harms and are implementable based on decision-making criteria that policymakers care about. So enter expert consensus methods that can be informative in this case. So in many areas of health and social policy, in the absence of strong empirical evidence, formal consensus methods can help clarify or at least shed some insight on which policies experts believe are or are not effective and implementable. And of the different expert consensus methods that exist, Delphi panels, or the Delphi method, is a prominent and rigorous method for eliciting expert consensus to generate guidance on health-related policies, again, when sufficiently conclusive scientific or empirical evidence is not available for decision-making. So we conducted an online modified Delphi process to identify expert consensus on the effectiveness and implementability of different components of state-level OUD treatment policies. So having gone over that rationale, I want to go a little bit into the approach that we use, how we operationalize the Delphi process through a method that we've called ROMPER, the RAND-USC OPTIC method for policy expert ratings. So we conducted expert panels again using this Delphi method, which involves assessing policies, discussing that initial round of assessment, and having a reassessment in light of the round one ratings and that discussion round in between the assessment and reassessment. So we conducted 2 online modified Delphi panels with no overlap in participants, one that was focused on policy effectiveness, which we call our effectiveness panel, and one focused on policy implementability, which we called our implementation panel. Panels involved a validated 3-round approach, so approach that we've used several times in different contexts using the RAND Expert Lens platform for conducting online Delphi panels. And again, this approach involves 2 rating rounds with a round of online group discussion and feedback in between. In round 1, experts reviewed, rated, and commented on 14 state-level policies. And then through an iterative process with the project team and advisory board, we selected these from a broader list of proposed or implemented state-level policies relevant for linkage to and retention in OUD. So I'll go over those 14 policies in a second, but that's how we decided on them. In round 2, experts discussed round 1 results using an asynchronous and anonymous online discussion board. So folks didn't know the identities of the individuals who were participating, and folks could sign in at times appropriate or relevant or amenable to their schedules. And they discussed the results from round 1. And then in round 3, informed by those round 1 ratings and that round 2 discussion, experts in the panel were able to reassess their views on the effects or implementability of each policy. We identified and recruited these experts in OUD treatment policy based on our experience in the area, off of recommendations from our advisory board and through the published literature. So we, as I mentioned, had 14 policies that we put through the panel. We categorized them into 4 broad categories. 5 of the policies targeted engagement with and linkage to treatment. Emergency department treatment linkage financial incentives provide monetary performance incentives to hospitals that attest that for patients with a diagnosis of OUD admitted to an emergency department, that they initiated buprenorphine treatment during the emergency department encounter and provided a warm handoff to outpatient treatment. The second policy facilitated access to medication for OUD, mandates that all substance use disorder treatment programs in the state facilitate access to medication for OUD. And that could be through the direct provision of the medication, through contracting with private prescribing professionals, or linkage agreements with other office-certified programs. Medicaid enrollment for individuals leaving jail or prison requires that correctional personnel initiate Medicaid applications or assist with Medicaid application information to individuals who are nearing release from incarceration, or that Medicaid managed care entities collaborate with correctional personnel to coordinate the discharge and transition of enrollees after release from a correctional facility. Forced drug treatment policies legally compel an individual to participate in and comply with treatment for OUD as an alternative to another form of sanction, such as incarceration, loss of child or custody, or loss of employment or receipt of benefits. And then the fifth policy in this category, involuntary civil commitment laws, are state statutes that allow family members, healthcare practitioners, or other persons to seek court-mandated treatment for an individual who poses a substantial threat of harm to themselves, for example, by overdose, or harm to others as a result of their substance use. Second category had 4 policies that aim to promote evidence-based and integrated care. The first hub and spoke type policies direct state or federal funding to implement multiple geographically based and coordinated care networks in which patients receive short-term intensive care until they're stabilized, and then they are referred to other outpatient practices for supportive services and medication for OUD in primary care settings or community-based practices. So each network forms a system of care with a primary organizing agency, the hub, and that agency, the hub, identifies, collaborates, and subcontracts with a network of substance use and mental health treatment providers, or spokes, to provide the integrated medication and treatment for OUD. The second treatment policy, pay-for-performance policies, make additional payments to medical and behavioral healthcare providers for improving the quality and value of the OUD treatment they are giving. Supplemental payments above the negotiated price for services are made through public or private health insurers to the providers based on predefined proportions of their client population, meeting specific benchmarks in the treatment process. The third policy, state Medicaid agency approval of collaborative care model reimbursement codes, formally integrates current procedural terminology, or CPT codes, to fund the collaborative care model in primary care settings. These codes are designed to reimburse billing practitioners, which is typically the primary care provider, for the cumulative time that the healthcare team has spent delivering components of collaborative care each calendar month, up to 130 minutes during the initial month and 120 minutes in subsequent months. Last policy in the second category, telemedicine-based collaborative care policies direct state and federal funding to implement collaborative care models for treatment of OUD, in which an off-site team of specialty-trained addiction clinicians collaborates with on-site primary care providers and their patients from a specialized location using technology like telephones, interactive video, and electronic health records. The third category had 3 policies that focused on flexible or longer duration treatment. The first, state medication for OUD drug formulary mandates. These require that insurers, both private and public, include at least 2 FDA-approved medication types for OUD on the preferred drug list or their drug formularies. The second, length of time Medicaid covers medication for OUD, is state Medicaid provision of coverage of medication for OUD for at least 6 months. And then full state scope of practice laws allow advanced practice providers, such as nurse practitioners and physician assistants, to prescribe medication treatment for OUD independently, that is, without a requirement for a collaborative agreement or post-licensure supervision. Then the last and fourth category, 2 policies for ongoing monitoring and support services, had 2 policies in this category. The first, drug toxicology testing requirements mandate that providers of medication treatments for OUD conduct at least 6 drug screens from patients in order to guide treatment planning. And the second, office-based buprenorphine treatment counseling co-requirement laws. These require patients receiving buprenorphine in the office-based setting to also receive counseling. And the state law does not explicitly protect against termination of buprenorphine treatment due to counseling non-adherence. So those were the 14 policies in 4 broad categories that we had experts assess. And we had experts rate these policies on effectiveness and implementability based off of something called the GRADE framework. GRADE stands for the grading of recommendations, assessment, development, and evaluation For those of you who do systematic reviews or have experience with clinical practice guidelines, GRADE is the approach underlying Cochrane and other systematic reviews that assess the effects of interventions. And then the evidence decision framework visualized here is then the process that the clinical practice guideline follows the guideline committee to assess different things like the benefits and harms of the intervention and concerns related to how implementable it is to come up with a final recommendation for or against the intervention and how strong that recommendation for or against is. The goal is to structure policy and practice decision-making around evidence on several important of these criteria. So in the absence of evidence, we still use this process to structure policy and practice decision-making around expert views on each of these criteria. So as I mentioned earlier, we had experts in two different panels, one focused on the effects of the policies, the other on the implementability of those policies. In that effectiveness panel, experts rated the direction and magnitude of each policy on 4 outcomes: treatment engagement, treatment retention, OUD remission, and opioid-related overdose mortality. And in the implementation panel, experts rated each policy on the GRADE implementability criteria, the feasibility, acceptability, affordability, and equitability of each of those policies. They were rated on 1 to 9 Likert scales. In the effects panel, that was 1, a very large decrease in the outcome, to 9, a very large increase. In the implementation panel, it was 1, not at all, feasible, acceptable, affordable, equitable, to 9, extremely acceptable, feasible, affordable, or equitable. In terms of the definitions for these outcomes, OUD treatment engagement involved the percentage of people meeting the criteria for an OUD diagnosis who received 2 or more OUD treatment services, including MOUD, within 34 days of initiating treatment. OUD treatment retention involved the percentage of people who met criteria for a diagnosis that remained continuously enrolled in treatment services for at least 6 months. Remission was the percentage of people meeting the criteria for an OUD diagnosis who did not experience OUD symptoms for at least 12 months. And opioid overdose mortality were the per capita rates of fatal overdose associated with opioids, including analgesics, illegal opioids, and synthetic opioids. Panel, we operationalize acceptability as the extent to which the policy is acceptable to the general public in the state or community where the policy has been enacted. Feasibility is the extent to which it is feasible for a state or community to implement the policy as intended. Affordability, the extent to which the resources or costs required to implement the policy are affordable from a societal perspective. And equity as the extent to which the policy is equitable in its effect on health outcomes across populations of people who use opioids. So last slide before the findings, the expert panel ended up involving 66 experts with various roles. So this included researchers, healthcare providers, human service practitioners, policymakers, and advocates. Hillary, can you see the slides okay? I think I just saw a comment saying that.
Yep, I can see them.
Okay, you can see the experts role?
Yes, I can see everything.
Okay, perfect. Just wanted to make sure. All right, so with ado, the new novel stuff. What did we find? And so this first section focuses on the policy ratings themselves, and then looking at all of the comments that we received, trying to make sense of the patterns of ratings that we've seen at the entire level of the panel. And again, this is where that conclusion we had about experts reaching consensus that supportive rather than punitive policies improve engagement and retention in OUD treatment. I think it's important to note that participants reached consensus on all outcomes across all policies, so there wasn't significant disagreement using our analytic method. So these final decisions reflect the median rating within a panel for a given outcome and a given policy. And then we developed themes that reflect policy recommendations, subgroup considerations, and implementation considerations following the GRADE approach that I mentioned earlier. But instead of being based on empirical evidence, they're based on the expert views in this panel. So here is a visualization of the final round ratings for the effectiveness panel, just to walk you through how to interpret this, each one of these rows is one of those 14 policies that I mentioned earlier. Each one of these is a forest plot that we've structured similar to forest plots and meta-analyses. A forest plot for each of the 4 effectiveness outcomes: engagement, retention, remission, and overdose. And then the dot here represents the median rating that is used to determine the decision. And then the bars here indicate dispersion of ratings. So the wider the bars, the more dispersion. If there was no bar, then the interquartile range is the same at the lower and upper end as the median. Then down here, you can see that from 1 to 9, it is a reduction to an increase in that given outcome. And per common practices for expert panels, we based overall decisions on the tertile that a dot fell in. So this being in the middle tertile would be little to no association with treatment engagement. From 7 to 9 would be consensus that there was an increase in treatment engagement, so on and so forth. So in totality, experts identified at least one policy that positively affected and at least one policy that negatively affected treatment engagement, treatment retention, OUD remission, and opioid-related overdose mortality. Across all policies, we thought it was interesting that correlations within a participant were consistent with the cascade of care for OUD. So any given individual was likely to see OUD treatment engagement, retention, and remission as significantly and positively associated with each other, and all as significantly negatively associated with opioid-related overdose mortality. As one participant noted, any increase in engagement gives more people the opportunity to be retained in care and thus be at reduced risk of overdose mortality and more likely to experience OUD remission. Of the 14 policies, experts rated 9 as yielding moderate to large increases in treatment engagement, with 3 policies further yielding moderate to large increases in treatment retention and subsequent moderate reductions in fatal opioid overdose. In contrast, experts identified 2 policies as having harmful effects on treatment outcomes or opioid-related overdose mortality. So there were some that folks actually thought were harmful for these outcomes. In terms of the implementation outcomes, again, similar to effectiveness, each row is an individual policy. Each one of these is one of the 4 implementation criteria: acceptability, feasibility, affordability, and equitability. 7 to 9 meant the experts thought that the policy was high on that implementation outcome, 4 to 6 moderate, and 1 to 3 low. And you'll see that most policies were deemed acceptable to the public. There was some more variability on the feasibility and affordability, with one as seen as having low affordability, and then much more variation in what the experts thought on the equitability of these policies. In short, 6 policies were rated as highly implementable across all 4 criteria: acceptability, feasibility, affordability, and equitability. And 4 policies were expected to exacerbate disparities in health outcomes. So let's dive now into why we're seeing these patterns at the high level, and then we'll go into considerations at more granular levels of policy categories and the policies themselves. So at the highest level of making sense of the ratings across the entire process, both effectiveness and implementation criteria, it seems that experts believed that policies that were high value, those that were effective, that were implementable, and that were equitable in their outcomes, generally involved supportive approaches, by which we mean approaches that are patient-centered, so those that increase options and allow patients in shared decision-making with providers to pick and experience treatment options that are amenable to their preferences and their individual needs. Policies that are rooted in reducing harm rather than those that are rooted in promoting abstinence and abstinence only, and those that are focused on increasing access to MOUDs and other evidence-based practices. So in contrast, experts seem to rate policies as low value, those that they saw as either harmful and or difficult to implement and potentially increasing inequities in their impact, to involve more paternalistic approaches. So those that involved coercive approaches or punitive approaches, those that were rooted in abstinence rather than allowing harm reduction to be something that was guiding the policy and its theory of change, and those that, again, punitively restricted evidence-based treatment access, potentially as a punishment for not meeting criteria. So these were the ones that, in general, were from where we sat making sense of the findings that the experts either didn't support, if not thought you should consider not implementing or de-implementing if you were currently implementing them in your context. In terms of important subgroup considerations, so things that might moderate views, experts generally appeared to emphasize that one needed to focus on facilitating continuous access of evidence-based treatment to specific populations, settings, and time periods that are associated with high risk for overdose if you wanted to meaningfully impact population-level opioid overdose mortality. So to provide a few examples there, justice-involved populations, particularly as they are leaving justice settings like jails and prisons, and people leaving the emergency department after an overdose were examples of these high-risk contexts, population settings, time periods that folks said, if those are targeted, you're really increasing the chances to have a positive, meaningful impact on population-level opioid overdose mortality. And then two key implementation considerations that kept coming up across panels and across policies were that equity must be centered in implementation plans in order to address disparities. While there were some policies that experts thought were more inherently equitable than others, they still emphasize that even a inherently equitable policy, if implemented poorly or in the wrong way or in bad faith, could still increase disparities, increase inequities. And so that it's not important only to consider policies when they're designed and put on the books, but really thinking through the entire implementation process to ensure equitable outcomes. They also mentioned across many outcomes and across panels and policies that stigma around OUD and MOUDs represent major barriers that need to be addressed at the individual, interpersonal, community, and society levels. So in implementation campaigns, continuing anti-stigma efforts for both the condition as well as medications indicated for the condition are key considerations for anyone who enacts these policies and is trying to implement them as planned. So the next part of the findings, I wanted to go through each of those decision criteria, the effectiveness of the policy, how acceptable it is, how feasible, how affordable, and how equitable, and our sense making of the ratings in the comments to help give you a sense of if you had a given policy presented in front of you, what is the likelihood that this panel at least would say they think that that policy is or isn't effective, implementable, and equitable. So in terms of effectiveness, the main theme was that policies need to meaningfully impact treatment outcomes to impact health outcomes. Not much of a shocker, especially after saying that the ratings kind of followed that cascade of care, where there was a significant positive association with treatment engagement and retention with reduced opioid mortality, overdose mortality. So if a policy doesn't meaningfully impact treatment outcomes, then you shouldn't expect it to meaningfully impact health outcomes. That said, there were also policies that they thought did have at least a small meaningful impact on treatment outcomes, but they don't necessarily translate to population level impacts on health outcomes. And there was three primary reasons that folks may have had this belief. The first was that policies that may narrowly focus only on treatment engagement and retention and limit their time frame of action to that proximal period limit their ability to affect more distal outcomes like remission and opioid overdose mortality. Secondly, there are a myriad of factors, as you know, that influence IUD remission and opioid overdose mortality. So it's just difficult for many policies to impact enough factors to a sufficient degree for meaningful and sustained population level impacts on overdose mortality. So speaking to, while we're considering policies in isolation, the entire evidence or the entire policy ecosystem that's in place and multiple policies might be needed to make those kind of meaningful and sustained population level impacts on overdose mortality. Policies might target a limited percentage of the population with OUD, and the smaller this percentage, the less likely that initial gains in treatment outcomes translate into meaningful impacts on population level health outcomes. A counterpoint to this is if that narrow focus is again on one of those subgroups, population settings, or time periods that disproportionately represent are disproportionately represented in opioid overdose mortality. And so if those are targeted, then you might actually see the needle move on opioid overdose mortality at the population level. So again, this is part of where that recommendation to consider those subgroups when you're planning a policy comes from. In terms of acceptability, the panel generally felt that the public supports efforts to end the opioid and overdose crisis, but that stigma remains a key barrier to the acceptability of some of these policies specifically. And namely, the general public still largely accepts punitive and paternalistic measures for people who use drugs as opposed to the supportive measures that the panel generally supported. And while persistent stigma towards individuals who use opioids is an issue, experts believe that the public does increasingly support policies that are effective in addressing the opioid crisis, but there still might be some concerns about using medications to do that and public funds to do that. So these would be important things to consider in the design and implementation of any policy to engage, to improve engagement and retention in MOUD and other. In terms of feasibility, there wasn't any policy that the panel thought was not feasible or had low feasibility. All were at least moderately feasible. The difference was dependent on the policy and the context. So within current healthcare, criminal, legal, and other systems that these policies are implemented through, there's at least some infrastructure there to make something moderately feasible. But highly feasible policies have either been demonstrated to already be achievable through precedent, like there are real-world examples and existing infrastructure. As an example, many states already have implemented state scope of practice laws that allow advanced practice providers to prescribe MOUD independently, so those got high ratings. And then whether or not something got a moderate or high rating depended on numerous factors like the availability of qualified healthcare providers and MOUD prescribers, norms in the local community, existing financial resources, geographical location like rurality, how complex the logistics of implementing a given policy were, and the political context. So all else being equal, if a policy doesn't address one or more of those factors, then the status quo when the policy is enacted and implemented will really influence whether they saw that policy as moderately or highly feasible in a given state or a given context. In terms of affordability, comments appear to balance considerations of societal cost effectiveness with the wrong pockets problem of those paying for the policy not being the same who receive those resource benefits or cost benefits or savings from the policy. So administrative burden, existing treatment infrastructure, healthcare industry trends that could offset costs, resources required to implement at scale, and staffing requirements were some of the things that came into consideration with that cost effectiveness, and particularly the cost part of the cost effectiveness. And again, experts frequently noted the importance of considering who pays for the policy and whether they are the ones who receive the primary benefit from paying for it. That's the wrong pockets problem. So the more that is likely to be the case, the less affordable it might be from a societal perspective. Experts considered a policy's affordability as contingent, not only on those resources that are required for that cost part of the cost effectiveness, but whether it was effective in the long term. So kind of standard cost effectiveness considerations, the least affordable policies, and or those that involved large immediate or continuing costs without subsequent societal benefits, resulting in societal cost savings. Those were the trade-offs folks were making. If it didn't involve a lot of costs and had large benefits, more likely to be rated affordable. If it had large immediate or continuing costs and or little benefit for those costs, not affordable. And the last criterion was equitability. And what experts appeared to be saying across policies was that they wanted to promote policies that are inherently inequitable by design, as well as those that could be implemented with equitability. And so what we mean by this is that equitability depended on whether experts perceive the policy as inherently inequitable, as well as concerns about the potential for inequitable implementation due to structural oppression and interpersonal biases in existing systems through which these policies are implemented, like the criminal, legal, healthcare, or other systems. They generally rated policies as having low equitability if those policies involved criminal legal approaches due to concerns about longstanding historical and ongoing structural oppression and interpersonal biases embedded within the criminal legal system. An example that came up frequently were the structural and interpersonal racism of the war on drugs and the criminalization of substance use. And this pessimism extended to healthcare approaches that involved onerous or punitive measures that, even if in design are meant to help support or monitor treatment, have the potential to be implemented inequitably through bias in the providers along social gradients like age, gender, geographic location, race, ethnicity, and socioeconomic status. Experts generally rated policies as having higher equitability if those policies inherently and explicitly targeted populations that currently experience disparities in not only the health outcomes themselves, but disparities in those treatment measures that we care about as well. And so sometimes there is this concern that equitability is only considered at the outcome level, but it's important to think about those process measures. And if folks are experiencing disparities there, to have policies that target disparities in those process measures, like treatment engagement and retention. However, experts also believe that disparities could be alleviated by broader policies that universally raise the minimum standard of care for everyone. So there was a bit more support for policies that experts perceived as, to use the saying, a rising tide lifts all boats. The last section of findings is digging a little deeper into themes by policy type, by those 4 categories that I went over when I defined the 14 policies in the panel. So when it comes to policies targeting engagement with and linkage to treatment, experts were generally in favor of the policies in this category that they believed support patients in receiving evidence-based care. They expect these policies to sufficiently increase treatment engagement enough to yield meaningful reductions in overdose mortality, and these policies to be equitable in their impacts through their focus on populations with disparate treatment and health outcomes related to opioid use. So given the substantial awareness of the overdose epidemic, experts believed that the public would increasingly support these policies as well that aim to facilitate access to evidence-based OUD treatment. In contrast, the experts were generally against the 2 policies in this category that they viewed as punitive and inequitable, and those were the coerced drug treatment policies and involuntary civil commitment laws. Experts anticipated these policies would have little to no impact on OUD remission and overdose mortality, and they further disapproved of the stigmatizing and paternalistic nature of these approaches, expressing concerns that the policies were harsh and exacerbated existing health disparities among marginalized communities who have experienced historical and contemporary oppressive practices. The second category, policies to promote evidence-based and integrated care, experts expected improved engagement in treatment from policies that focused on improved access to high-quality care. So as an example, hub-and-spoke and telemedicine-based collaborative care policies were ones that they expected to improve treatment retention through improved coordination and continuity of care. Those were ways that they operationalized and increased access and attention to engagement and retention in care, were coordination and continuity of care. They further expected improvements of treatment engagement and retention from hub and spoke type policies to yield increased remission and overdose mortality, likely because of that attention to that continuation of coordinated care. So not focusing just on that proximal time period, but really focusing on OUD as a chronic condition and that kind of chronic care. It's found all policies supporting increased access to continuous high quality and patient-centered care as acceptable to the general public for addressing the overdose epidemic, in part because those seem to be trends on public views for healthcare approaches generally. And high equitability was associated with policies that inherently facilitate better patient and community engagement. So things that have engagement in their theory of change and how they're implemented, or those that might promote standardized and objective quality measures that might mitigate against the ability to subjectively and differentially implement those policies by providers who might have interpersonal biases along social gradients. In contrast, they expected minimal to no effects of pay-for-performance policies, and this was specifically because experts in their comments said that the evidence that real-world implementation of these models tends to underperform. They had views on feasibility that depended on existing infrastructure, on how well cooperation was happening among providers and organizations and precedent in a given area. The affordability depended on existing resources and the perceived cost effectiveness of a given policy in this category. And moderate equitability was associated with quality of implementation. So again, these concerns on how well or not well these could be implemented equitably across populations, and the infrastructural status quo within a state. So for example, if the bandwidth in rural areas for internet was poor, then things like telehealth might be more of a concern in terms of equity of the impacts. The third category, policies that allow flexible or longer duration treatment, or at least aim to do so. Experts found all policies in this domain to be highly implementable on all four criteria. So they thought the public supports efforts to do things like expand insurance coverage and access to effective medications generally, that the policies are relatively more feasible to implement once enacted due to precedent, so evidence that these have been feasible in certain states in the past, and existing infrastructure that is available in most, if not all, states, and affordable, mostly due to long-run cost effectiveness from the societal benefits of scaling MOUDs. So this was a category where that affordability was really influenced by the effectiveness element of the cost effectiveness equation. And they thought that these were all generally equitable given their inherent focus on societally disadvantaged populations that experience systemic inequities. So they thought that in design, these policies really did focus on subgroups, populations, settings, timing that was really important for an equity perspective. However, experts expected meaningful improvements on treatment engagement and/or retention, but they expected trivial effects on OUD remission and overdose mortality. They thought there was more of a focus on that initial period to improve engagement and retention, which could be enough of a reason to implement these policies, but other policies might be needed in conjunction to see the subsequent desired effects in reduced overdose mortality. And finally, the fourth category, policies for ongoing monitoring and support services. This was the least supported category, as both of these were seen as the kind of punitive measures that in general the panel was less supportive of compared to more supportive measures. They did receive high public acceptability ratings due to, again, some of the concerns that were raised about what is or is not acceptable to the public, or at least certain constituents within the public. But despite this high public acceptability, experts expected these policies to have minimal to no effectiveness, to have moderate feasibility and affordability, and to, in particular, exacerbate inequities. And there were two chief concerns that they had in essentially opposing these policies. First, they were worried that these policies can potentially act as a deterrent to treatment engagement and retention for many patients. So instead of actually helping engagement, monitoring and support as implemented could actually deter folks from engaging, if not staying in treatment. And that these policies can exacerbate disparities when they're used as punitive measures in practice, and that these inherently had more of an ability to be used differently by different providers and different organizations as a punitive measure, and thus that concern that they could, in implementation, exacerbate disparities. So I wanted to end with some conclusions, reiterating some of these themes that we saw for high versus low value policies, and then again, introduce the policy profiles that we've created for each individual policy that I have slides for in the appendix of this if folks wanted to ask about particular policies today, or if you were interested going forward that you could look at yourself, and of course, get in touch if you had any follow-up questions. So in short, the study presents consensus of experts about which policy states could consider either adopting or not adopting, or if they have already adopted them and de-implementing in their efforts to improve treatment for OUD and help address the overdose crisis. It seemed like the panel was 4 policies that we considered using supportive approaches. So those that are patient-centered, that are rooted in harm reduction, and are focused on increasing access to MOUD, greasing the wheels, opening the floodgates, rather than creating those kinds of barriers in that last category of policies. The experts generally thought that these had a better chance of improving engagement and retention in OUD treatment, and of the 2 really high-value policies subsequently impacting OUD mortality, overdose mortality, reducing that rate at a population level. Conversely, they seem to be against policies that they saw as coercive as taking an abstinence-only approach. So, happy to consider approaches that are harm reduction, and for some folks, if abstinence is the goal, to support that. But if it's abstinence only, there were concerns about those policies, and policies that appear to use or enable the use of punitive and restrictive measures as part of their approach, as inherent to their theory of change. They emphasize in terms of subgroups that policies need to focus on at-risk populations, settings, and periods to prevent overdose mortality, and that policy implementation should center on equity to address stigma and disparities. And so we hope that in addition to making sense of the policies that were in this panel, that this can also provide perhaps some insight if you are thinking about combining policies or are considering policies that weren't covered in this panel, the sort of thinking and rationale that went into these ratings, and that can help you think about something that we didn't assess. So how supportive versus punitive is the policy? What are the subgroups that are being focused, if any, by the policy? And are we thinking through implementation, particularly equitable implementation to achieve equitable outcomes, and the stigma that surrounds both the condition of OUD as well as medications for opioid use disorder? And we think that based on the ratings of the effectiveness criteria and the implementation criteria, and equitability as a really important single criterion, that there were two specific high value and two specific low value policies. So thinking specifically about the policies that were in this panel, the two high value policies were emergency department treatment linkage financial incentives policies and Medicaid enrollment for individuals leaving jail or prison. These were policies that the experts thought are implementable on all criteria and are likely to have sizable and equitable effects on treatment engagement, treatment retention, and overdose mortality. These have the characteristics of those things that they support that I mentioned: patient-centeredness, supportive approaches, increasing access, focused on high-risk contexts, population settings, and/or time periods, and that are partly inherently inequitable and better enable equitable implementation. And so that's these two specific policies appear to be the ones that they supported the most and have the strongest expert consensus for a given state to consider adopting, or if you have adopted it, to continue implementing it. In contrast, the two policies that appeared to be low value were drug toxicology testing requirements and office-based buprenorphine treatment counseling co-requirement laws. And at the patient level, these might be things that in a shared decision-making encounter, using patient preferences and clinical best judgment for a given individual might be appropriate. But at the level of a state policy, of a mandate for an entire state, experts were concerned that that could negatively affect all outcomes at the population level, might only be moderately feasible and affordable given the resource requirements for these policies, and might be likely to increase inequities due to their potential for that inequitable and punitive implementation. And so from there, expert consensus on the remaining policies varied to seeing them as more or less highly or low valued policies. But on the bookends, these were the most high value and the most low value policies based off of effectiveness, implementability, and equitability of the policy. So to conclude, I wanted to give you an example of our OPTIC policy profile, and this is even at a high level. The policy profiles go into much more detail, but for each of the 14 policies, we've created a web page on the OPTIC website and a PDF that you can download of that web page to store in your own files or to print and share with your colleagues, where we provide what we think is the overall policy recommendation using the expert ratings, whether they would support, oppose, or we're not sure where the panel would stand in general on a given policy. Then we go through the summary of the ratings of effectiveness and implementation that informed our judgment as to whether the panel would be likely to support, oppose, or we're not sure where they stand if they were actually in a practice guideline and had to give a recommendation. And so these green dots in beneficial indicate that the consensus is that they thought there would be a positive effect on a given outcome. A gray dot in this little to no means that there were minimal to no effects on an outcome. And then if there's anything in the harmful column, it means that they actually think it leads to a decrease in engagement, in retention, and remission, or an increase in mortality, respectively. And then similarly for the 4 implementation ratings, whether they thought it was high on each of these criteria, moderate, or low. And it's these combination of ratings that would inform our sense of whether the panel would be likely to support, oppose, or we're not sure where they'd stand on a given policy. And beneath that, in these policy profiles, we provide a high-level summary of expert comments. So similar to what I did category by category, but instead at an even more granular level of policy by policy. Didn't do that today, as that would make this an hour-and-a-half webinar, and I'm sure an hour is more than enough for you all. But if you're keen on a particular policy, it goes through at a high level what the experts said about their ratings on the effects for each of the outcomes, affordability, acceptability, feasibility, and equitability. And then we have below that even more detail for each of those outcomes. What the overall rating was is shaded in, the summary of expert opinion for that rating, for that outcome, for that policy. And then we even provide a anonymized representative quotation. So to give an example for this policy, which I believe is Medicaid enrollment for individuals leaving jail or prison, the reason why the consensus opinion was that this would have a beneficial impact on OUD treatment engagement is that it addresses an important barrier to initiating treatment for a priority population. And then here's an example quote serving as warrant for that theme that we comments. Given the extremely high risk of overdose following release and the challenges of access to treatment following incarceration, notably from lack of insurance, this intervention is likely to promote initiation and engagement in treatment following release. So that can also really give you the evidence of how we came from the comments to summary of expert opinion for a given outcome for a given policy, to themes to the policy, themes to policy categories, themes to criteria, and for the whole panel. And here we also do have, where it existed, the summary of expert opinions for dissenting or minority views. So even though there was consensus, right, limited dispersion, that doesn't mean that there weren't some members of the panel who thought differently. And so when that was the case, we also captured those dissenting views in these summaries on the policy profiles. So for example, providers who thought there was little to no impact of this policy on treatment engagement said that the paperwork and processes to activate coverage can take too long, and coverage has limited impact without coordinated linkages to timely treatment. The quote, one quote supporting that, even when a patient or client has enrollment paperwork done prior to leaving the jail, it is often not in effect quickly enough for medication to be covered the day they leave. Often the processes to reactivate Medicaid are not followed appropriately, which also causes gaps in care. And even 1 to 2 days of a gap in care can result in a person returning to use. So we wanted to capture those dissenting views as well, so you get the full sense of the complexity of expert views, if that might help you think through things like implementing a policy that you support but might want to know what challenges there might exist, or if you know that there might be dissenting views or stakeholders in your context, what views they might have, so you can prepare to incorporate, address, have a trusting conversation with those views as well. So with that, I want to thank you again so much for your time today. The OPTIC website has those policy profiles, as well as links to the 2 journal articles we published summarizing what we've gone over in the presentation today.